Okay, thank you very much. So, a bit of a change of tack now. So I'm going to talk about paediatric thrombosis. And these are the topics that I'm hoping to cover over the next half hour. So I'm going to talk a little bit about the incidence and risk factors, and I'll try to contrast these with adult practice for you. I'm going to talk a bit about thrombosis management, and I'll particularly do this in relation to specific situations, and we'll go through some cases. I want to talk a bit about prevention, which we're beginning to sort of address in children, and then I'll come back to what David's been talking about, DOACs, and where they fit into paediatric practice and where we've got to with those. So, one of the things we're very clear about in venous thrombosis is the very strong correlation with age. So as seen here, you've got this very depressing, for those of us who are aging, graph that shows this horrible, relentless increase in the incidence of VTE with age. And if you're a male, it's probably even worse. However, it starts from a low baseline, and on a population basis, the incidence of venous thrombosis in children is actually very low, and it's actually really quite an uncommon condition in otherwise healthy children. If we break that down and then we look at the age distribution in paediatric practice itself, you see quite an interesting phenomenon, because you see this peak in the first year of life, a relatively low level throughout childhood, and then a starting to increase again in adolescence. And the drop-off, this is registry data from an old UK registry, but all the registries show the same sort of pattern, and the drop-off at 16 is just where people start transitioning into adults rather than any difference in 16-year-olds. So there's been quite a lot made about this peak in the sort of under ones. And it may be something about under ones, and actually it's predominantly not under ones, it's predominantly neonates, particularly preterm neonates, and it may tell you something about the risk of hemostatic or thrombotic problems in neonates, and they may be particularly susceptible. But if you look at the hospitalised population, this graph does reflect the hospitalised population, and it may be as much that this is a graph indicating that neonates are particularly exposed to the risk factors that cause venous thrombosis, rather than something particularly specific about neonates themselves. Now, although on a population base, venous thrombosis is relatively uncommon, in the hospitalised population, it is something we're seeing more frequently. This was a study that was published by Leslie Ruffine's group in 2009, and they looked at the incidence of thrombosis in different age groups over a period from 2001 to 2007, and they were able to demonstrate a significant increase over that period of time. Bottom right shows you all age groups, and then it breaks it down. And again, as expected, the adolescent group has got the highest incidence, and actually it's not the under ones, it's the preterm babies that are showing the higher level. But we've got this relentless increase, which I think reflects, and everybody sort of agrees that this probably reflects more intensive management, better survival, better awareness, better diagnostic methods for detecting venous thrombosis. And that study was done between 2001 and 2007. I'm sure if you did it between 2011 and 2017, you would see a further increase, because I think this is something we're seeing increasingly. If we think about risk factors, there's a lot of commonality in terms of risk factors between adults and children. If we look at numbers of risk factors, there is, however, a significant difference, because this is a registry study of 200 children presented with VTE in the UK, and of those 200 children, less than 10% were idiopathic. So most children will have some risk factors, and many will have multiple risk factors. If we look at the individual risk factors on the right, there is quite a lot of commonality with adults. But the thing that is really sort of strikingly different is at the top of the list, the association with central venous lines, and that crops up in virtually all studies of paediatric thrombosis and is different from adults. So we've got a very high proportion of secondary VTE. We know that CVLs, in most studies, CVLs are the single most important risk factor, and as a de facto consequence of that, we're really seeing a very high proportion of upper limb venous system events rather than lower limb DVT, as you might expect to see in adults. We do have guidelines for management. But in contrast to your adult studies where you've got, I mean, David's presented lots of lovely data showing hundreds of patients in different studies, but we're in his low-level groups with low levels of evidence. So much of the recommendations are from a low evidence base. They tend to be more consensus than strongly evidence-based. I think we are in a situation now, and I'll come to it when I talk about the DOACs later on, where things are beginning to change. One of the problems has been it's been very difficult to run paediatric studies, but we are getting, because of the regulatory the regulations around licensing of new agents, we're now in an era where we are running paediatric studies, and for the first time we're probably going to get into prospective clinical trials that are going to provide some better quality data, which will hopefully improve the quality of these guidelines. So what I want to do now is just consider some of the issues and uncertainties around management of some of these events. And I'm just going to present 3 different scenarios just to sort of highlight some of the problems. So the first one I want to go through is a 10-year-old boy who's got acute lymphoblastic leukemia. And he's been treated on the UCAL 2011 protocol, and he's going through induction with regimen B, and he's got to day 17. He's got a Hickman line in situ in his left internal jugular vein. There have been some issues, as there often are, with poor sampling and a bit of a sticky line, so he's had some urokinase put in his line. But he's now got a bit of shoulder discomfort, a wee bit of arm swelling, and he's had a Doppler carried out, and he's got a partially occlusive clot in his left internal jugular vein. So he's got a symptomatic upper limb venous thrombosis during ALL induction therapy. Sorry. So now, of course, this is not a particularly unusual event. ALL is a particular risk factor for thrombosis, and I'll come back to that in a minute. In different studies, there's been quite a lot of data published on this. There's an incidence of between 1 and 37%, depending on the definition, the study design, and the diagnostic methods, and whether you include symptomatic or asymptomatic events. That's a very wide parameter. There was a meta-analysis published in 2006 that included 17 prospective studies with almost 2,000 children, which demonstrated an incidence of 5.2%, with the majority of events during that period occurring during induction, although actually that was probably changed now, and with our current ALL protocols, we're seeing a lot of later events as well. Anyway, it gives an idea of the frequency. Just further data from that meta-analysis, if you look at thrombotic events in ALL, they're quite an interesting group. They kind of divide into the CNS events and non-CNS events, but you'll see further down here that upper limb CVL-associated thrombosis does comprise quite a significant group. So this boy is in keeping with what we might expect to see. It is an interesting area. The risk factors that contribute, or the mechanisms that contribute to thrombosis in ALL, are quite multifactorial, and they represent factors in the host, the disease, the treatment, and concomitant toxicities. And they're listed here. I'm not going to go through them all in detail, but I think if we pick out the most important factors are probably age from the host, and the treatment, particularly the use of central venous lines, and particularly asparaginase. And asparaginase is probably one of the most important factors, because it induces quite an interesting and significant coagulation disturbance during treatment with this agent, with an effect on synthesis of a number of proteins, including antithrombin, but also plasminogen and asparaginase. And the concomitant use of steroids, which increases factor VIII and von Willebrand factor, really results in quite a significantly prothrombotic state. So back to our boy. And I'm just going to run through 1 or 2 questions about how we might manage that. I'm not going to ask you about it, but you can be thinking about how you might do that. So should the CVL be removed? And if yes, when are you going to remove it? What is the correct type of anticoagulation for this boy? What is the correct duration of anticoagulation? How are you going to manage thrombocytopenia? This is a boy who's on chemotherapy. He's going to be thrombocytopenic. How are you going to manage that? Is there a role for thrombophilia screening? Obviously, with David in the audience, I'm to be very careful what I say. And should this, very importantly in a child with leukemia, is should this child be re-exposed to asparaginase, which has probably been very contributory to the event. There's a lot of uncertainties with regard to the management, and a lot of dilemmas around the management, because, as I've said, there's not a good evidence base. So a few years ago, as part of a sort of kick-off to writing a guideline, we decided to survey UK centres treating children with leukemia and ask them this sort of question to see what their responses were. And it was actually quite interesting. This data's now been, or this survey's now been published. So we asked them a number of questions, and I'm just going to run through them very quickly. So we asked them if they would got a CVL-related thrombosis. We asked them if they would remove the line. And you can see here, so more than half said they would always remove the line, and a lower proportion would keep the line in. 38% would only remove if it was non-functioning. We also asked about the duration of anticoagulation, and again you can see quite a bit of variation from between the biggest group would give sort of between 48 and 72 hours of anticoagulation, but there's quite a spread in how much anticoagulation would be given before the line was removed. So quite a bit of variation in practice, I think you'll agree. We asked about the duration of anticoagulation. If you're familiar with the guidelines, you'll know that standard therapy for thrombosis in children is for 3 months of treatment. But you can see that this was attenuated. Around 50% said they would give a minimum of 6 months, so quite a spread again, with various caveats, depending on whether the thrombosis was symptomatic or asymptomatic, whether the line was left in, results of re-imaging studies, and ongoing risk factors. We asked about how thrombocytopenia would be managed. The majority of people felt that 50 was a safe cut-off for anticoagulation, so there seemed to be reasonable consensus on that. But in terms of how the platelet count be supported in a child going through a chemotherapy protocol who would be significantly thrombocytopenic, there's quite a bit of variation. So 57% said they would support the platelet count and continue. 13% were going to reduce the dose, and almost a third were going to hold the anticoagulation until the platelet count recovered. And in terms of re-exposure to asparaginase, and asparaginase is an important component of leukemia therapy, and there is data, older data, to suggest that if you drop asparaginase during your treatment, you will have a survival disadvantage, so it is an important agent. So we asked about re-exposure and when they would be re-exposed, and whether you would give thromboprophylaxis during exposure or re-exposure. And the majority of people did want to re-expose, but not necessarily in the same block. Some would wait until later, and the majority would give some sort of thromboprophylaxis to cover that, but not all. So with these things in mind, well, let's go back through our questions and see how we think we might manage this boy. So should the CVL be removed? Well, you saw from the data that the majority of people would probably consider removing the line. There is very little data to direct the practice here. And there is some adult data, which was published in 2007, suggesting that there wasn't a particular increased risk of either recurrence or progression if the CVL was left in situ. And the issue about CVLs in children, and it crops up in children with ALL and children with other things, is that if you remove one line, you may just have to put another one back in. You're going to expose the child to a general anaesthetic, perhaps very soon after removing the initial line. So I think there's a general feeling that if the line is functional and if it is still required, and that's a key issue, then it may be appropriate to leave it in. What is the correct type and duration of anticoagulation? Anticoagulation is usually given in this scenario with low molecular weight heparin. Different from adults, there is not evidence in children. In adults, you know that low molecular weight heparin is the preferred agent in cancer patients because it has been shown to be advantageous over warfarin. We don't have that evidence in children, but really it's a logistical issue. This child is going to have lots of interruptions, is going to be at risk of bleeding, will need theatre visits, lumbar punctures. So using low molecular weight heparin is pragmatically an easier choice. Duration, standard duration is 3 months. but that is potentially curtailed depending on the timing of the event and the ongoing treatment, and possibly also on the response to treatment. How should thrombocytopenia be managed? The general recommendation is that you should support the platelet count probably for the first 4 weeks of anticoagulation, and then you can either reduce the dose or you can omit while they're thrombocytopenic. But an initial period of anticoagulation without interruption is probably easier. And a lot of these patients are outpatients, so it's actually probably easier to support the platelet count than to be wondering when you're going to stop or when you're going to reduce the dose. Is there a role for thrombophilia screening? In general, thrombophilia screening in children who've got secondary events is not particularly helpful. The only scenario in this situation where it might be useful to do some thrombophilia monitoring is to measure antithrombin if you were running into problems with heparin resistance due to the reduced antithrombin levels we see in children on leukemia therapy. But this in practice is probably a fairly uncommon scenario. And would you re-expose to asparaginase? I think that has to be yes, it's an important part of treatment. But you should do so with anticoagulant cover. Not clear whether that should be at therapeutic dose or at prophylactic dose, but important that there's some anticoagulant cover going on. And these recommendations are part of a BCSH guideline that we've written on the management of hemostatic problems in children, which is currently in press. So we're doing a change scenario here a little bit and think about a different sort of case. But you saw the data on the risk in neonates. So here we've got a 26-year-old preterm ventilated neonate who's 3 weeks of age and has an incidental finding on ultrasound of a non-occlusive thrombosis within the IVC. Previously had an umbilical catheter in situ, which had been removed 10 days earlier. So again, line-related associated clot, this time more of an incidental finding. So, questions here, perhaps slightly different. Perhaps the question is actually, should you anticoagulate this baby? You might think, well, somebody's got a clot in their IVC, and that sounds a bit dire. I might want to do something about that. But I think it is something that has to be considered very carefully in this age group. If you're going to anticoagulate, what type of anticoagulation are you going to use? And again, is there a role for thrombophilia screening? So I think this is all about risk-benefit. And the risks in a neonate, particularly preterm neonate, are all about bleeding. Does the baby have a documented interventricular hemorrhage? Have they had necrotizing enterocolitis? Are they thrombocytopenic? Do they have a coagulopathy? All things that might adjust your risk-benefit here. The line had been, the umbilical catheter had been inserted after delivery and had been removed 10 days previously. So this is probably a clot that's been present for a little bit of time. The site of the clot in the IVC, how high, how low it is, may impact on your thoughts, and the presence of comorbidities. So, you know, whereas you might assume that this is a risky situation to not anticoagulate, but in these babies it has to be a very careful risk assessment. And you know, the most recent case that we dealt with, we didn't actually anticoagulate the baby, we simply monitored the clot. It was probably an old clot that had been associated with the initial line. We monitored for any progression and didn't anticoagulate. So non-anticoagulation in a preterm baby is not particularly an unreasonable scenario. If you're going to anticoagulate, are you going to use unfractionated heparin or low molecular weight heparin? We use a lot of low molecular weight heparin in babies, but it can be problematic. Babies that are poorly perfused or edematous or don't have much subcutaneous tissue will not do well with low molecular weight heparin, and in that scenario, using unfractionated heparin may still be preferable. And duration will often curtail the duration of anticoagulation in preterm babies, particularly due to the risk of bleeding. And one final scenario, the other end of the age spectrum, a 15-year-old girl with extensive left femoral DVT, diagnosed at second presentation to her local ED, and had initially presented with groin pain and then came back with groin pain and quite significant swelling of her leg. And this issue of adolescence and failure to recognise thrombotic problems is quite a big issue. When we've looked at it, there's quite a high risk of patients representing and delays in presentation, particularly children presenting or adolescents presenting with pulmonary embolism. So she had a number of underlying medical issues. She had severe eczema, she was autistic, she'd had a recent hospital admission to the dermatology ward for management of her eczema, and she'd been put on the oral contraceptive pill for menorrhagia. So questions for her. What is the correct type and duration of anticoagulation? Again, additional questions, should we think about thrombolysis? How should we manage our menorrhagia? Is there a role for thrombophilia screening? And most importantly, could this event have been prevented? So thoughts for her. Standard management would be low molecular weight heparin, either continuing or low molecular weight heparin converting to warfarin. Thrombolytic therapy probably should be considered. There's very, very little data on thrombolysis in children and adolescents as a group. But as you know, in adults, there is some data to suggest that it may be beneficial in particular subgroups, particularly where there is limb-threatening compartment syndrome. One of the issues with thrombolysis in children is, if you want to do endovascular thrombolysis, is that most pediatric, standalone pediatric units don't tend to be set up with good IR to facilitate this, and it's something we're only beginning to be capable of. So whereas if you're in a shared unit where you've got access to adolescent, to adult interventional radiology, you may be able to arrange this. In a standalone pediatric unit, that may be more challenging. How should our menorrhagia be managed? Obviously, we have to manage that in some way. And the options are to switch to a progesterone-only oral contraceptive preparation, and it's really about the timing of doing that. Again, thrombophilia screening, this was a precipitated event, so there's probably no reason to, it's not going to alter management doing thrombophilia screening, so we would probably not opt for that. But prevention is important. I'm going to come on to that. Now, when we talked about the type of anticoagulation, I could have been controversial and said, would you have given her a DOAC? The trials, as we'll come on to in this age group, are ongoing. And she was actually fortunate enough that we were able to recruit her into the Einstein Junior trial, which we were participating at the time. And she was actually randomised to rivaroxaban, which she was delighted about because it was a lot less hassle to her to come up and have her trial visits than other forms of therapy. We treated her for 3 months and we switched her to a progesterone-only contraceptive preparation. Okay, so I'm going to, just for the last bit, change tack and talk a little bit about prevention. So I've shown you that the incidence of venous thrombosis in children is increasing. Mortality directly attributable to venous thrombosis is relatively low, probably around about 2%. But it is associated with very significant morbidity, problems with venous access, pulmonary emboli, post-thrombotic syndrome, and very significant increase in healthcare costs because it does prolong hospitalisation. This CHIPS study from America, which is the Children's Hospital Solutions for for patient safety, identified that hospital-acquired venous thrombosis was a common cause of what they deemed to be preventable harm. Now, in adults, thromboprophylaxis and prevention of thrombosis is well established, risk factors are well defined, and prevention strategies are in place which are evidence-based. But in paediatric practice, we're really quite a long way back from having that in place. We know something about risk factors. We don't have an awful lot of information about the weighting of risk factors. So this is much less well defined. We are seeing a different spectrum of venous thrombosis. We're not just seeing DVT, lower limb DVT. So we're trying to prevent a different sort of event. We're trying to prevent predominantly CVL-related events. And actually, there's not a lot of good literature published to suggest that these are readily preventable events using thromboprophylaxis. So prophylactic strategies are, the efficacy is unproven, and it's not absolutely clear who we should target. So if you think back to the graph I showed you at the beginning, showing the increased risk throughout life and the increase in starting in adolescence, perhaps the adolescent group are the ones to start with. And we have an informal group of paediatric haematologists in the UK who are interested in thrombosis, and we've done a few studies together. And we decided to have a look at venous thrombosis in our adolescent population with the aim of defining risk factors and also trying to assess the preventability, if you like, of adult VTE in the ones we looked at. So this was VTE events at our centres between 2008 and 2014. It was a retrospective study, and we actually excluded upper limb CVL related events because we were more interested in lower limb DVTs and how we could prevent them along the same lines as adult treaters might do. So we had 76 cases, 41 males, 35 females, so again seeing this slight male predominance, with a median age of 15 years, and the pie chart here shows the distribution of events. So lower limb DVT making up the majority, but with a significant chunk of sinovenous thrombosis and pulmonary emboli, and then a smaller number of other events. We documented risk factors, and these are shown here. And down at the bottom, you'll see that surgery, malignancy, and reduced mobility, however you define that, and it isn't particularly well defined, but reduced mobility compared to normal were important risk factors. So then we went on and we tried to assess preventability. And as a group, we assessed these events against an adolescent risk assessment form for venous thrombosis. And this is an example of a form, and you'll recognise that. Those of you who work in the UK will recognise that this is the style of the Department of Health NICE-based guideline or assessment chart for venous thrombosis, and we've just adapted this a little bit for use in adolescents, and we've piloted that in several of our centres. So we assessed against this. It basically aims to identify thrombotic risk factors and bleeding risks, which might want you to might mean that you didn't want to give pharmacological thromboprophylaxis. So this is our group of 76 adolescent VTEs. We divided these up. We had outpatients, and 28, as seen over here, had no underlying diagnosis or no obvious provoking event within 3 months. It's not to say these were idiopathic events at all. They were quite interesting, and actually idiopathic events, truly idiopathic events, even in adolescents, are really quite uncommon. So there were quite a high proportion of thrombophilias and oral contraceptive related events. Of our others, we divided them into those with an underlying diagnosis and or a provoking event within 3 months, and then there was 20 inpatients on the far side. And then we tried to divide them, or we did divide them into those in which there was no indication for thromboprophylaxis, those in whom it was contraindicated, which were 9, obviously very small numbers here. These were predominantly children who'd had recent brain surgery or spinal surgery, and a group in which we felt thromboprophylaxis using that risk assessment would have been indicated. And we identified that just under 20% were potentially preventable events using some kind of thromboprophylaxis. So it's preliminary data. There's an awful lot more work to be done in this area, but I think it is important, particularly now that we're having adolescents treated in children's hospitals. Our own hospital now routinely takes children up to 16 years of age, that there is some provision for assessing these children and giving thromboprophylaxis to adolescents who are at increased risk. In terms of the rest of the hospital population, things are at a much earlier stage. This is a study that was aimed to do a systematic review and meta-analysis of risk factors and risk assessment models in children across the paediatric age group. And it's a sort of 3-step process, initially trying to identify risk factors and develop risk assessment models, to then validate them, and then to start looking at VTA prevention trials. And at the table at the bottom, this is just a snapshot of some of the data that came out of this meta-analysis. This was particularly looking at the case control studies, which perhaps give the best quality data. And you can see there were 4 factors that came out as being significant. The first was admission to ICU, second the use of a central venous line, mechanical ventilation, and length of stay in hospital. But although these things came out in the meta-analysis, if you look at the odds ratios, 2.14, 2.12, they're not all that high. So these factors are not discriminating terribly well for us. You'll note that age is not there, and that's really because a lot of the case control studies actually matched for age. The other area where we're quite interested in thromboprophylaxis or preventing thrombosis is in the area of ALL. You'll remember the patient we presented at the beginning. Strategies include general risk reduction measures, stopping oral contraceptives in people who are going to be exposed to asparaginase, issues around the use of CVLs, timing of insertion of lines, the type and site of the lines. But it's probably going to boil down to some kind of therapeutic intervention, which could either be done in all patients or in selected groups, and you might select by age. In ALL particularly, there's a very strong influence of age on the incidence of these events, and there are scoring systems in development for trying to assess and trying to delineate the highest risk groups. There's a choice of intervention. Antithrombin deficiency associated with the use of asparaginase is an important factor. So there has been interest in antithrombin supplementation, either with FFP or antithrombin, or anticoagulation, either with low molecular weight heparin or coming soon, hopefully, oral agents. Just in the last minute, just or two, just run through quick studies. There's been a lot of interest in antithrombin supplementation. The quality of the data in trials is not particularly good. And this was a study that compared antithrombin supplementation compared to antithrombin supplementation with low molecular weight heparin, and did show a small but significant difference, reduced in risk with antithrombin supplementation along with low molecular weight heparin. Antithrombin supplementation alone did not seem to benefit. Low molecular weight heparin alone, however, this is data from adults, has not shown a clear benefit. Again, a lot of this is small studies, not very well controlled studies. A lot of them are using historical controls. But in this study that was published in 2016, there was no significant difference seen between adults treated with low molecular weight heparin. What this group then went on to do was they went on to intensify the dose, and it may be that they've got the dosing is wrong and you do need more intensive treatment. And they presented an abstract at ASH in 2016, which suggested a trend, not a significant difference, but a trend towards improvement with a more intensive dose. DOACs will have a theoretical advantage of anticoagulating without involving antithrombin. And that may have an advantage in this particular population where antithrombin is depleted. There are no reported studies at the moment, but they are all ongoing, both in adults and actually also in children. I'm going to skip back past these in the interest of time. And just two slides at the end just to talk briefly about DOACs in children, where we're at. The regulatory, as many of you will know, the regulators now include a paediatric investigation plan when new agents are being trialled prior to licensure. They usually follow on from adult studies, and this was always going to be the case for venous thrombosis because of the lower risk. The indications and the trials are usually mapped from adults. So that there's a case for looking at where the drugs are used in adults and seeing if there's an indication in children. If there's not an indication, then the drug company can apply for a waiver. If there is an indication in children, then it's usual for phase 1 to 3 studies to be established in children. Phase 1 and 2 studies are very similar to adult studies, PK and PD safety studies. Phase 3 studies, again, similar to adults, randomized studies. However, the caveat here, and although these studies will produce improvement in data for children, there is still a problem because venous thrombosis is so much less common in children. It's still difficult to recruit to these studies, so they're not going to be superiority studies. They're probably not even going to be non-inferiority studies, most of them. However, they will aim to show biosimilarity in the paediatric age group with data on efficacy and safety, and are still likely to be a step forward for us compared to the data that we have. Where do we use anticoagulation in children? What are the indications and how would you map the adult studies into pediatrics? Well, we obviously manage venous thrombosis, DVT, pulmonary embolism, particularly sinovenous clots. We're interested in prevention, although there's not a very clear pathway for that at the moment. And actually, if you think of our long-term use of anticoagulation, we have a big use in cardiac patients for children with congenital heart disease, particularly children who've undergone what are called Fontan procedures for things like univentricular heart, and also a number who will have had heart valves early in life. So currently, we have recruiting in the UK studies ongoing for the management of VTE with the phase 3 studies with dabigatran, rivaroxaban, apixaban and doxaban. There's a prevention study that I've alluded to in relation to using apixaban with ALL-related thrombosis. And there are phase 3 studies just rolling out with rivaroxaban, doxaban, and a phase 2 with apixaban for cardiac indications. So hopefully we will generate some data from these studies, and hopefully these agents will come into paediatric practice because they obviously have huge potential for the avoidance of parenteral anticoagulation and the monitoring of these young children. So just to conclude, venous thrombosis is a significant and an increasing problem in tertiary care paediatric populations in particular. Evidence base for treatment remains limited, although hopefully is going to improve. Prevention strategies are needed and are in development. And new agents trials are up and running now, and I think we can say that the DOACs are coming to paediatrics as well. Okay, thank you.